Thank you guys for joining us. This webinar is part of a series brought to you by the University of Iowa College of Public Health and Iowa Immunizes to celebrate the HPV vaccine's 20th birthday. This is our 5th session, and all sessions are recorded and made available on Iowa Immunizes' YouTube channel. So in today's webinar, we will hear from Dr. Heather Brandt, the Senior Director of the HPV Cancer Prevention Program at St. Jude Children's Research Hospital. She's a co-associate director for outreach at St. Jude's Comprehensive Cancer Center and a full faculty member in the Department of Epidemiology and Cancer Control. As a social, behavioral, and public health implementation scientist, her research program focuses on addressing cancer-related health disparities, specifically through HPV vaccination. This research includes working with subject matter experts, thought leaders, and partners to effectively implement evidence-based interventions and strategies to increase HPV vaccination coverage. We will have time for Q&A at the end of Dr. Brandt's presentation, and we encourage you to ask questions in the chat throughout. With all that said, please go ahead and get us started, Dr. Brandt.
Thank you so much, Stephanie. Give me a moment here to share my screen. All right. Well, I am really excited to be here with you all this afternoon. Some of you know that I am a native of Iowa. I grew up in Iowa, northeastern Iowa, to be exact. My parents still live in Dike, Iowa, a small town outside of Waterloo, Cedar Falls. My sister lives in Des Moines. I still have lots of aunts and uncles scattered all over the state. Iowa will always be home to me. So I'm very excited to have the chance to talk with all of you today. Always like to do this for my friends in Iowa who I've continued to work with on HPV cancer prevention over the years since graduating from the University of Iowa many years ago. Go Hawks. All right. So 20 years ago, when HPV vaccination came on the scene, we really hoped that HPV vaccination would prevent cancer. And today, we know it does. So the question is no longer whether HPV vaccination works. The question is whether or not we can deliver it equitably to eliminate HPV cancers. My disclosures are shown here. So to get started, I hope all of you can access the chat. Just use the chat to answer this question. When you hear 20 years of HPV vaccination, what comes to your mind? And I'm going to open the chat to follow along while you guys are responding. It's also really nice to see so many familiar names and also so many new names here in the participant list. So answer this question in the chat. Let me know when you hear 20 years of HPV vaccination, what comes to mind? Lower cervical cancer rates, lives saved, absolutely. Cancer prevention success, 20 years of cancer elimination, particularly cervical cancer. How has it been 20 years? I often think about that. Progress, success, kids going to college, being protected, kids getting vaccines. Thank you for saving lives. 20 years of advocating, 20 years. Wow, they keep saying this one is too new. It's a young adult now, right? I know it'll be legal to consume alcohol next year. How has it been 20 years? Lots of those coming through. As we really reflect on the last 20 years of HPV vaccination, it really is such a tremendous scientific advance. But even more than that, it's an advance in preventing cancer and saving lives. I think all the time about the people who were vaccinated yesterday and being vaccinated today who are protected against HPV cancers that they could develop in the future. That doesn't just affect individuals, that affects families, that affects communities. That's what HPV vaccination has given us over the last 20 years. So before we talk about the challenges that remain, I want to start with what's gone right over the last 20 years. So June 2026 marked 20 years since the first HPV vaccine was approved in the United States. And so this has given us 2 decades of real world experience and evidence. So when HPV vaccination was introduced, as I said, we hoped it would prevent cancer, and now we have proof that it does. And across the next several slides, I'm going to highlight 3 types of progress. Progress in our understanding of HPV-related cancers, progress in HPV vaccination coverage and implementation, and then progress in outcomes, including declines in HPV infections, precancers, and cervical cancer in particular. So the story of HPV vaccination over the last 2 decades is truly one of extraordinary scientific success. And the challenge now before us is making sure that everyone benefits from that success. So most cancers caused by HPV are almost entirely preventable. This is what makes elimination possible. 20 years ago, we already knew HPV caused a substantial burden of disease. It causes 6 different types of cancer and several non-cancer outcomes, including genital warts, recurrent respiratory papillomatosis, or RRP. Tens of thousands of people in the United States continue to be diagnosed with HPV-associated cancers every year. And recognizing the burden really created the urgency to develop and implement HPV vaccination. So although cervical cancer may be the most well-known, there are, of course, many others that fall below the tip of the iceberg, as shown here in this graphic from the CDC. And that's not to count the hundreds of thousands of people who have a cervix, who experience a precancer each year, including those who have been diagnosed with genital warts and also RRP. And this is costly not only in terms of dollars and cents. HPV-related diseases, total direct medical expenditures actually are estimated to be over 9 billion with a B dollars annually, second only to HIV if we consider HPV as a sexually transmitted infection. It's also very costly in terms of the burden people who are diagnosed with an HPV-related cancer endure, and the loss of lives and the influence that has on families and communities. So HPV vaccination really offers us such an awesome opportunity. So shown here are HPV cancer incidence rates. These are the most recent, just released recently as part of the U.S. Cancer Statistics Working Group data release for 2023. Also 2019 to 2023 data are available. There is an increase in the annual rate, up from 12.2 cases per 100,000 to 12.9 cases per 100,000 in 2023. And one of the things that you notice here are geographic patterns that really show the concentration of the highest incidence. And the high incidence is largely driven by oropharyngeal cancers, those cancers that occur at the base of the tongue and tonsil area in the oral cavity, and cervical cancers. And for the last several years, 3 states in particular have had the highest rates of HPV cancers, and those are West Virginia, Kentucky, and Oklahoma. And in general, through this region of the southeastern United States, getting into the Ohio Valley, Appalachia regions as well, we see high rates of HPV cancers. So HPV vaccination, as we know, is a preventive vaccine. Currently available vaccines are not therapeutic, talking specifically here about the only HPV vaccine available in the United States for the last several years, which is Gardasil 9. And HPV vaccination recommendations have evolved with the science. They've expanded and matured over time. So vaccination coverage has certainly increased substantially since the introduction of the vaccine in 2006, with millions of adolescents who have been protected through vaccination. And although coverage remains below national goals, which I'll get to momentarily, we're vaccinating far more adolescents today than we were over a decade ago, yet gaps remain. And so while we've made progress, and it's always important, I think, to celebrate progress, we also have a lot more work to do. So shown here is that traditional CDC adolescent vaccination coverage figure, and HPV vaccination coverage is consistently lower than other routinely recommended vaccinations, as shown here. And in some parts of the US, when we look at vaccination initiation, which is what this one or more dose map is showing, in some parts of the US, we're doing really well. And in some parts of the US, we're not doing so well. So shown here is the HPV vaccination initiation by state and jurisdiction. These are 2024 data. 2025 data should be published later this month or early next month in MMWR. You'll note there's wide variability in coverage across the country, ranging from the lowest in Mississippi to the highest in Puerto Rico. Iowa sits at just under 72%, according to NIS teen data. Of course, in Iowa, you have a very robust immunization registry that tracks HPV vaccination initiation and up to date. And the Iowa coverage of just below 72% is shown here in the lightest color. Coverage is generally lower in the Southeast. It's generally higher in the New England area and South Dakota. And it's always important to note NIS teen data really give us insight in trends over time. And they provide a really nice and useful snapshot for that purpose. But there's sometimes such extreme variation from year to year, depending on the sampling framework and response rates, that sometimes we can see some wide fluctuations, which is why it's nice to look at it over time. So this slide shows state level coverage for HPV vaccination up to date. So completing the series as scheduled based on initiation age. And in terms of the Healthy People 2030 goal, which is specifically for 13 to 15-year-olds, these data shown here, 13 to 17-year-olds, we fall short. But nationally, some states like Massachusetts are coming very close to and are achieving the national goal. Again, coverage ranges from lowest in Mississippi, in this case, highest in Massachusetts. Iowa sits at about 60% here for up to date, making it in this lighter blue color. And you see a similar pattern here for HPV up to date as with HPV vaccination initiation. And I haven't shown the data here necessarily. I have some data on the next slide, but for this same age group, coverage for Tdap or pertussis vaccine, whooping cough vaccine, is at about 91%, and meningitis or MenACWY vaccines are at 90%. So that's really an important marker and understanding for the threshold. So national progress in HPV vaccination coverage certainly is real, but it is not evenly distributed. We see communities and states that have achieved much higher protection than others. And these geographic patterns really can help us to understand where additional work is needed. And they also show us that higher coverage is possible. So shown here is estimated adolescent vaccination coverage by MSA or Metropolitan Statistical Area status. And so mostly urban, mostly suburban, and mostly rural are the three categories that are used in these data. Importantly here, you can note that the darkest green color, the bar all the way over on the right-hand side for each of the vaccines, so Tdap, pertussis whooping cough first, MenACWY, HPV initiation, and then HPV up to date from left to right across your screen, you'll note that for rural communities, all of these coverage estimates are lower compared to urban areas. And shown here are differences in HPV vaccination coverage overall, comparing rural and urban settings. And Iowa is a mostly rural state. And there are a lot of people in Iowa who drive many minutes to access health care if they can't access that locally in their community. And we see here that HPV vaccination coverage remains lower in mostly rural areas compared to mostly urban areas. And the magnitude of the difference in coverage is large. It's about 11 percentage points for initiation and for HPV up to date based on 2024 data. And recently, with Dr. Jason Semprini and others, we've been publishing papers examining these differences in HPV vaccination, rural urban coverage, and looking at HPV cancers as well. We find that these differences are not getting smaller. And 20 years ago, we saw HPV cancer rates being nearly equivalent across rural and urban areas. And now we see that gap widening. So that just speaks to the urgency and importance of addressing HPV cancer prevention with rural communities. So Sandy Pigali of the CDC has presented these take-home points previously about NIS teen data, and I always like to borrow them from her and also appropriately attribute credit to her because what they tell us is that the challenge is no longer proving the vaccine works. It's ensuring everyone receives it. Coverage remains lower than desired. It still lags routinely recommended adolescent vaccines. There are a lot of adolescents who remain unvaccinated each year, and progress has really slowed and stagnated in some areas. And importantly, we know the rural urban divide is increasing, as I just referenced, and we see wide coverage differences by state. And there are so many research questions that derive from this in trying to understand why we see such higher coverage here and not here. Is this driven by access to care? Is this driven by penetration and influence of HPV vaccination misinformation that infiltrates healthcare systems and providers as much as it does the general public? What are the drivers of these changes? And certainly they're complex, they're multi-level, and likely multifactorial or multi-component within each of those levels. So this big picture perspective I've been sharing this year in a number of my presentations because I think it gives us just kind of a look across the landscape to consider the current context and conditions. I hear all the time from people who are healthcare providers and professionals recommending, educating on, and administering vaccinations about the confusion, about the chaos that's happening in this space. Which guidelines do we follow? Do we follow the ones that say we're like Denmark that came out in January of this year? Do we follow the before times, ACIP, MMWR, CDC endorsed guidelines? Do we follow the AAP guidelines? Which guidelines do we follow? And all of that contributes to underlying uncertainty and really erodes the confidence in vaccination recommendations, the science. The CDC website now does not or now indicates a potential link between vaccines and autism versus previously where there was clarity in reflecting the science to say that to date there has been nothing found to show that vaccinations are linked to autism. These all influence the broader landscape and especially vaccinations like HPV, which have come under the limelight over the last year since introduction. Prior to COVID-19 vaccines being introduced, HPV vaccines were far and away the most studied vaccines in history. So that just goes to show the continued distrust around this that circulates around this vaccine. Now, with that said, the data I just shared with you show that it is a vocal minority that dominates the discourse around this topic because most parents and families are choosing HPV vaccination for their kids. But certainly the current context and conditions influence what we see unfolding. So we've heard an awful lot of promising news about reduced dosing regimens for HPV vaccination, specifically one-dose HPV vaccination. Globally, implementation of one-dose programs, especially in low and middle income countries, are going to make enormous differences in reducing the burden of cervical cancer in particular. The World Health Organization, or WHO, made the decision to use a reduced dosing recommendation because of the global burden of cervical cancer. Something is better than nothing in many of these areas that do not have the opportunity to have well-developed, well-organized, well-resourced screening, follow-up care, and treatment programs. And so this change by the WHO to single dose was actually done before single dose trials had been fully completed, even though they were certainly in progress. So the current evidence around one dose, which is an important part of the looking back where we are today and looking forward, the current evidence for a single dose shows very strong protection against HPV 16 and 18, which cause most cervical cancers. The Escudo trial, which enrolled more than 20,000 participants, showed conclusively that one dose was non-inferior to two doses when examining cervical endpoints with high effectiveness against HPV 16 and 18. And this was observed among bivalent, so the 16-18 vaccine, as well as the nonavalent vaccines. However, there were some gaps in what we know and understand about single dose. We still don't know long-term durability of protection. We don't know about protection against non-cervical HPV disease. That's particularly concerning here in the United States with growing, increasing rates of oropharyngeal cancers that are linked to HPV, also genital warts, RRP, et cetera. And we also don't yet have information on which groups, which age, which conditions are going to require multiple doses. So these are important gaps that remain in our evidence. So since 2006, people have received more than 500 million doses of HPV vaccine globally. This clinical experience has generated a very large body of research, including safety and monitoring data. The latest Vaccine Integrity Project review and Cochrane review evidence really reinforces what we've seen for a very long time, and that is that HPV vaccination is very safe. Across millions of participants, hundreds of studies, researchers have found no evidence that HPV vaccination increases serious health problems related to vaccination and continues to show substantial benefits for HPV cancer prevention. So this is a very safe vaccine. So after 20 years of HPV vaccination, the most important number is maybe the simplest, and that's zero. So zero is not just an aspiration anymore. We're beginning to see real world examples where HPV vaccination is changing what is possible for cervical cancer prevention. So these headlines from Scotland, England, Australia, and other settings show us something historic, that when HPV vaccination is delivered on time, consistently, and at high coverage levels, cervical cancer becomes rare and potentially non-existent as a public health concern. So this slide really is meant for us to pause and understand the progress before us here. For decades, cervical cancer was and continues to be viewed, for those who are diagnosed with it, experiencing it, surviving it, as tragic and just as an expected outcome. But now we have evidence that the future looks very different. Zero cervical cancer cases, zero cervical cancer cases deaths, zero families losing someone to a cancer that we can prevent. That's the promise of HPV vaccination, and that's the progress that we've been witness to. This isn't just hopeful messaging. The science behind these numbers is very strong. It remains consistent, and it continues to grow. And so we no longer have to say, HPV vaccination should prevent cancer. And this is a question that came up all the time early on. Like, how do you really know this prevents actual cases of cancer? We now know that HPV vaccination does prevent cancer. Here's just a few snippets from studies. Researchers in Scotland who reported zero cervical cancer cases. In England, we saw huge reductions in precancers and also in cervical cancer rates. We have seen, in spite of slow uptake and coverage levels in the United States, we've also seen tremendous declines in cervical precancers here in the United States. This is why vaccinating on time matters. The largest benefits are seen, of course, before there's a possibility of exposure. And this is why routine vaccination at ages 9 to 12 is so incredibly important. And the impact that we're seeing in the United States really adds to that evidence. HPV vaccination is preventing cancer. And so the challenge that is before us continues to be making sure that everyone has the opportunity to benefit. So HPV vaccination prevents cancer. It works so well that we're starting to see long-term gains. Now, this study, which was presented by the ACS, came with some additional questions about the data availability and the data analysis and such, but really provided us with some additional real-world evidence that showed higher vaccination coverage in the US is translating to lower cervical cancer rates. And so researchers found that for every 10% increase in vaccination coverage, that it was associated with nearly a 12% reduction. So in this case, it was showing us that when vaccination coverage goes up, we see cervical cancer go down as well. A recent study has also been focusing on durability, looking at the long-lasting protection that's provided by HPV vaccination. This study showed that there was no evidence of waning protection up to 18 years. So when we look across the last 20 years, HPV vaccination has been shown to be safe, effective, and providing long-lasting protection. The question again persists on how well we can deliver these benefits equitably and consistently enough to ensure that everyone has the opportunity to prevent HPV cancers and also lead us towards elimination. So the last several slides I've spent kind of reviewing quite remarkable progress when we think about it. HPV vaccination is preventing infections, precancers, and cancer. Yet progress hasn't been distributed equally. Geography still predicts cancer risk in the US, and rural communities, lower resourced areas, and parts of the Southeast continue to see lower vaccination coverage. So the challenge is it's really no longer this scientific uncertainty. It's really ensuring that where a child lives doesn't determine their future cancer risk. I know that colleagues in Iowa and those who are living there understand this very intimately with the rising cases of overall cancer rates and understanding the environmental influences on such observations. So our challenge here is really focused on implementation activities, and elimination is only going to be possible if we're able to reach every community, not just those who have the strongest health systems, that have a blue governor, that have progressive public health policies. We have to think about reaching everyone, and the children most at risk may be the least protected. So the remaining gaps really are not evidence gaps as we think about where we need to invest our efforts. They're really implementation gaps. So 20 years ago, those big scientific questions of, is it safe? Does it work? Is the protection going to last? We have answers to those questions. So today's barriers are much more practical and even more complex, I would argue. Implementation, trust, policy environments, workforce capacity, thinking about misinformation, and access really now determine whether individuals benefit from these scientific discoveries in HPV cancer prevention. And although not a focus of my talk today, important to mention, we're seeing commensurate advances in cervical screening, looking at self-collection, looking at the role of at-home collection, just a wide range of innovation happening across the space. In HPV vaccination, we know what works. The challenge is how can we deliver it at scale? So the future of our HPV cancer prevention efforts centered on vaccination really depend less on scientific discovery, though that continues to be important. It really depends on effective implementation. And the US has made substantial progress, but we also see that some of this progress has slowed. So this is the socio-ecological model. I've cited Dr. Grace Ryan here, who of course has ties to the University of Iowa and other faculty members who were also part of this publication. So when we take the socio-ecological model and apply it to HPV vaccination, these are just some selected examples. There are many levels of influence that can cultivate gaps in why an individual is not vaccinated, why families aren't choosing vaccination, why we find communities at risk of vaccine preventable diseases because of how these different levels all operate. So this model applied to HPV vaccination really shows how social and policy factors shape the possibilities of individuals when it comes to HPV vaccination. So this means that those who are marginalized, their vaccination experiences can look very different by what's available to them. There's trickle down effects of favorable and unfavorable conditions, and those shape the decisions and opportunities of individuals as well. And while individuals can absolutely lead change upward and outward in this model, it's very challenging when taking on system and structure level forces. But it's hard to doubt individual ingenuity and agency and how that can transcend some of these levels. But these factors all work together to really erode confidence, limit access, create senses of doubt, and really foster environments in which vaccination does not get chosen in different individual encounters. So, why aren't more children being vaccinated against HPV? Well, these barriers operate across multiple levels of influence, as I just showed some selected examples on the previous slide, when aligned with the different levels of the socioecologic model. And most families are not refusing HPV vaccination. I think the evidence is showing us this. It's many children aren't receiving a strong recommendation or a convenient opportunity to be vaccinated, as much as we do know that there's increasing pushback. So this means that these barriers that are being experienced are potentially modifiable. So this just shows another look at the different levels and different factors that could influence vaccination status and really can open us up to more gaps in who has access, who doesn't, who's getting vaccinated, who's not, who's getting a recommendation, who's not, and how those can all work against each other and work together to create a vaccination environment that becomes very complicated. So if we could choose one intervention that has the greatest potential on HPV vaccination coverage, a strong provider recommendation certainly rises to the top. Across multiple studies over many years, a strong provider recommendation has remained one of the strongest predictors of whether a child receives HPV vaccination. And the healthcare provider recommendation influences the confidence of the parent, caregiver, or person making the vaccination decision. A recommendation influences urgency. A recommendation helps normalize HPV vaccination as routine cancer prevention. And the most effective recommendations are presumptive. They're brief, they're confident, and they're given along with other adolescent vaccinations at the 11 to 12-year-old age range. And a similar approach can be used when recommending HPV vaccination at ages 9 and 10. And every single clinical encounter really represents a cancer prevention opportunity. So the encouraging news, when we think about gaps, the gaps are not in the evidence, it's in implementation of the evidence at scale. We don't need to invent new solutions. We know many of the strategies. It's just matching up the right information or right strategy at the right time, delivered by the right person. That's a lot of rights to have to get right in order to see them all align. But that's really where we are. And those are implementation challenges. And we're experiencing these implementation gaps, and we need to address them at scale to increase coverage. So these strategies are strategies that work. how can we implement them broadly and consistently enough to reach elimination? So after 20 years, we see very clear science. We know HPV vaccination prevents cancer. We know what can increase HPV vaccination coverage. We know that multi-level approaches, including some of what has been shown in the previous few slides here, can also help reduce disparities. And the path forward isn't necessarily discovering what works, it's how it works and how it's being implemented to meet the needs of communities that are experiencing coverage gaps. So the path forward really is centered on implementing what works at scale and what's necessary to eliminate HPV cancers. So in the first 20 years, we've been building the evidence. The science is strong. And the next chapter is really about applying what we've learned at scale. So around the world and across the United States, organizations are increasingly using the catalyst of elimination to build on the momentum around vaccination, screening, timely follow-up care, and treatment. And elimination planning is a very active segment of the current dialogue in the US. Elimination's becoming the organizing vision of our collective efforts with HPV vaccination as one of those three pillars. I know that many countries are pursuing cervical cancer elimination goals, with Australia and Scandinavian countries appearing to be really at the forefront there. And the US has the opportunity to dramatically reduce future HPV-associated cancers with centering some of our momentum around these combined approaches to elimination. So today's vaccination decisions most certainly determine cancer incidence decades from now. And so our urgency is clear. So 20 years ago, I think elimination would have sounded awfully ambitious. And today, elimination is actually a realistic public health objective being added to state comprehensive cancer control plans almost universally. We now have vaccines that can prevent infection, screening, and increasing modalities of screening to help intervene on precancers and also identify disease early for cervical treatment that's going to prevent progression. So the question is really about how are we implementing at scale? It's not a scientific fantasy anymore. I remember thinking back to when HPV vaccination, the monovalent trial results were published and thinking, oh my gosh, this is really extraordinary. And these scientific advances don't just come around all the time. And so it's really an exciting time. And this challenge of elimination is being embraced globally. So one of the most important developments that really started and catalyzed these efforts around elimination was the WHO's decision to call for global elimination of cervical cancer as a public health concern. So this was really the first time that there was an acknowledgement that cervical cancer should no longer be considered inevitable. We have all of the necessary understanding and tools available to stop almost every single case of cervical cancer from ever happening. And so how do we get those into practice at scale? And the economic And this multi-state effort really generated needs assessment data, a very iterative planning process. And then Louisiana came as the next state level plan, and it adapted a model to its own context through the Bayou Blueprint. And what's encouraging here is that the plans are similar but not identical. They've all embraced the pillars and such, but there are unique differences that all show them pointing in the right direction based on their context. We see that Alabama has really centered a lot of their efforts on an implementation model. The Southeast has embraced a menu-based approach for regional facilitation and implementation. I'll share a little bit more about a regional approach. Somebody already noted this in the chat, but the reason why I think a Midwest regional approach makes so much sense is because some of the states proximal to Iowa are making great progress. How can you all create and cultivate a learning community and environment? And I know some of that is already happening. I've seen those collaborations, heard about those collaborations, but regional approaches really can offer some advantage. They also can offer some safety for states where there may not be as much support centrally for various regions. And Louisiana really took on an adaptation approach. So despite some differences across the existing plans based on audience, geography, and approach, I should mention lots of other states are planning to release their elimination frameworks and plans this calendar year or early in 2027. These plans really center on the three main pillars. They also very clearly showcase the importance of partnership and collaboration around planning, implementation, and tracking and monitoring, and some accountability. So there's a lot of alignment across the plans. There's also some unique differences. And I think those unique differences are critical and important at the state level to really, local jurisdiction level, to really ensure that you're accounting for conditions and context. We also are learning a lot about metrics. Available evaluation data. Learned recently that a central cancer registry in Florida is exploring including precancers as part of its routine reporting requirements and thinking about how for many years precancer of the cervix reporting data has been virtually non-existent outside of closed health systems that are tracking it in some other strategy or possibly through claims data. So there certainly are some data limitations around each of the three pillars that need to overcome, but the creativity and innovation that's happening in states that are moving forward with plans is really inspiring and offers a lot of idea generation for states that are experiencing similar challenges. So the Southeast, as already noted, has been facing really high HPV cancer rates, low HPV vaccination coverage. And so it was with this in mind that the call to action from the HPV Vaccination Roundtable of the Southeast was released about 11 months ago. And it really represented a shift from just talking about elimination to actually planning for it and putting forth a call to action. It created this shared regional framework across states while recognizing again that each state has to adapt implementation activities locally. And all of these elimination resources are available through the stjude.org/southeast-elimination. You can scan the QR code or go to that webpage to access these. This is an at-a-glance look with the three pillars with the primary goals shown here. We want to note that these support strategies are suggested approaches and require review at each state and jurisdiction level to make sure that there's alignment with local needs, opportunities, and preferences. And down along the bottom are the elimination support strategies that the Southeast Roundtable is committed to. And you'll notice how these goals mirror what we've learned over the last 20 years. They focus on the same pillars, and this framework is really intentionally simple because the challenge is in execution appropriately. So that's where all of the different strategies come into play. So another thing we've learned over the last 20 years is that evidence alone doesn't change outcomes. People need tools, partnerships need infrastructure, and states need practical resources. And so these implementation support resources for elimination were developed to help move from the call to action of awareness to implementation. So the rationale here is really simple. No one should have to start from scratch. And that has been crystal clear from the Alabama team, the Southeast Roundtable team, and also Louisiana and others. There's so much collaboration in this space right now. So this slide highlights examples from the implementation toolkit that supports the call to action for the Southeast. And you can also request access to the elimination toolkit through that same web page. So here's the QR code again, and also including the vanity URL to be able to learn more. Lots of promotional materials. Our team also is happy to share the information we've gathered. There are a lot of existing resources. No one has to start from scratch when it comes to elimination planning. So as we step back from elimination plans, toolkits, and implementation strategies, I think it's important to pause and appreciate how far we've come. 20 years ago, we were hopeful. Now we're informed by evidence. 20 years ago, we still had some questions. Today, we have answers to almost all of those questions. 20 years ago, we hoped HPV vaccination would prevent cancer. Today, we know it does. So as I conclude and take your questions as time allows, I want to reflect on some of those broader changes from then and now. Our science has certainly matured. Elimination of cervical cancer as the first type of HPV cancer has become the goal, and implementation is now really the work before us. So I've shared this timeline in previous talks, and I think it really showcases how far we've come. This does not even begin to start back in ancient Egypt with possible evidence of HPV-related diseases. But this slide does give a high-level overview of major milestones, starting with the HeLa cells, the cells from Henrietta Lacks that really led to the scientific discovery of the etiological link between HPV and cervical cancer. We've continually followed the science and focused on protecting kids today from cancers they may develop in adulthood. Again, the changes and shifts in guidelines really are driven by science, driven by the innovation that's been happening in the space. And so I think that it's important to really take a look that in 2006, it was trust us, this really works. The science we have today says so. We had strong clinical trial data, but we didn't know whether or not we would see actual cancer prevention. And at that time, because of available clinical trial data, the conversation was really centered on cervical cancer, cervical precancers, recommended only for girls for that reason. And so we still had some important unanswered questions. How long would protection last? Would immunity wane in any ways over time? Would we eventually need booster doses? Some of y'all have been around long enough to remember those conversations. And today, those questions have largely been answered. We have so much real-world evidence showing the effectiveness, safety, and durability of HPV vaccination. We understand more about its etiological link. It's now, of course, gender neutral for many years. We have more than 18 years showing durability. And so perhaps the most important shift from 2006 to 2026 is that hope has really been replaced by actual scientific evidence. We no longer believe that HPV vaccination will work to prevent cancer. We actually know it does. So a few things, I tried to come up with 20 things we've learned in 20 years. This is much harder than it sounds. I'm really not sure why I undertook this endeavor. It's a lot more difficult than I think I expected, but it's easy when there's such strong science to come up with 20 things we've learned in the last 20 years. And I think all of these center on the evolution of the science around HPV vaccination. We have very strong safety, effectiveness, durability data, And now it's up to us to put into practice what we know works to be able to protect kids today from HPV cancers in the future. We know that for rural communities who face unique challenges, there also are unique opportunities there. We know equity is an important underpinning. Implementation is the big challenge now, not discovery. We know that for elimination, vaccination is one of the three pillars. And most importantly, elimination is possible if we act to implement at scale. And that's really the charge before us. So in June, we celebrated 20 years. So much data and evidence before us when we think about HPV vaccinations, cancer prevention potential. We also know that the science is incredibly strong. We've seen so much good work come out of clinical trial data, ongoing safety and monitoring data, descriptive statistics and implementation trial data, a wide range of understanding the implementation context, what determinants are of implementation, and how we can put those into practice. New data just continue to come out routinely, finding cancer-related benefits beyond cervical cancer, finding cancer-related benefits among males. We're seeing emerging evidence continue to support reduced dosing while research continues. A lot of strong science already exists. And we know that implementation remains that major challenge. There continues to be persistent geographic variability, lower vaccination in rural communities, state level policy and procedural differences. The Vaccines for Children program has been instrumental in delivery of all routinely recommended vaccinations, including HPV vaccination. State 317 funds, incredibly important. Allocation of additional state resources, also very important. Setting the federal poverty level at least 200% FPL, also important, but lots of variability in that policy area. Missed opportunities exist, and we know that there continues to be inequitable access to prevention services. So facts matter a lot, but gosh, trust is what really is determining whether and how those facts are accepted. So trust, misinformation, and the changing vaccination environment matter. We know now that vaccine hesitancy is driven by much more than just knowledge deficits. That may be one part of it, but is usually not the entire story. Vaccine decision-making is influenced by trust, social influences, family dynamics, cultural beliefs, previous experiences with vaccines and with healthcare providers and health systems, access barriers, and more. Provider recommendation is so important. I recently heard Dr. Noel Brewer reiterate the evidence around this, and it really is incredibly remarkable to see how important this continues to be. And also because of the heightened vaccination hesitancy existing in these discussions between a provider and someone making a vaccine decision, the announcement approach training and evidence-based cancer prevention and control program has evolved to include research-tested counseling messages to address main concerns of those making those decisions, using motivational interviewing and other techniques. And communication training for healthcare providers is becoming a major priority. But if we're serious about eliminating HPV cancers and truly leaving no population behind, rural communities have to be central to that solution. We need to make sure that implementation strategies are aligning with rural communities. Rural communities are not monolithic, and our approaches to increasing HPV vaccination coverage also should not be monolithic. Rural focused, rural developed, rural informed, rural owned, rural operated communication and outreach activities designed for rural communities by rural communities are really important components here. So we can accelerate our progress by making HPV vaccination routine cancer prevention. We think about the progress that we've made, the gaps that exist, and the potential for elimination. The challenges are real, but it's very possible to remain highly optimistic. We're not starting from scratch. We know what works. We know that we can move forward, move the evidence and science forward. We have an enormous opportunity to focus on populations and communities that have historically been left behind, including rural communities where we see higher HPV cancer burden and vaccination gaps that are elevated. Every child who's vaccinated today is really one less person at risk for a preventable HPV cancer tomorrow. So we have the tools to eliminate HPV cancer, starting with cervical cancer as a public health concern, but realizing this opportunity really depends on what we do today. So thank you for your attention, and I look forward to answering your questions.
Thank you, Dr. Brandt. That
You're
was a great
welcome.
presentation. Lots of love in the chat for you. We do have one question. How well do HPV vaccines work in the immunocompromised?
So, hey, Al, shout out to Al. Al and I've known each other a long time in this space. HPV vaccines have shown to work really well among those who are immunocompromised. And that includes people who are living with HIV, have had robust immunogenic responses. Childhood cancer survivors also have had robust immunogenic responses. Those trials have largely been based on 3-dose regimens, regardless of age at initiation of the first dose. I think that continues to be really important. The Children's Oncology Group recommends 3 doses for childhood cancer survivors. For those who are living with HIV, 3 doses continue to be recommended. Those who undergo transplant are also recommended for 3 doses. So we see that among those who are immunocompromised, when they receive the recommended 3-dose regimen, that their immunogenic response has been really robust. I also see a question from Rachel. Are there any plans to provide draft language to states for what they could add to their cancer plans regarding HPV elimination? So through the HPV Vaccination Roundtable of the Southeast, we've been trying to capture that language that's been included across different state cancer plans. I believe Florida was one of the first to include elimination language in their state cancer plan. And many other states since then have been adding this language. We have actually found that adding this language to the state cancer plan is really an important precursor to elimination planning in a state because you've already set the stage. Many plans already include HPV vaccination, cervical cancer screening, perhaps timely follow-up care, maybe treatment, but for sure HPV vaccination and cervical screening. So the elimination goal really opens up the potential for centralized coordination, collaboration, and partnership-driven elimination planning centered around that state comprehensive cancer control goal. So please reach out to us. This is something we've been getting more requests for to be able to share some of the blurbs that are included. So thank you for that question.
Hey Heather, it's Jason.
Hi,
Thank you
Jason.
for coming back to Iowa. Hey, could you comment on the progress of the Southeast work groups for the medical students and when that might be ready for adapting in a place like Iowa?
Sure. So, as part of the Southeast Roundtable, we have 3 priority actions, and one of those is centered around starting at age 9 and implementing other best practices. And there has been a working group developing a medical school training curriculum that we are pilot testing to understand how we can integrate this type of communication training and promotion of HPV vaccination coverage. I'm not exactly sure of where that stands, but would be happy to get back to you with an update about it. We know that the demands of healthcare providers today in practice look very different than 20 years ago. And so how can we prepare them for these important conversations around vaccinations with communication training and others? So please know I'll get an answer kind of on the status of that and be able to get back to you. The Southeast Roundtable will be releasing soon an updated age 9 resource guide that includes the amazing resources of the National HPV Vaccination Roundtable at ACS, also other existing resources that are sort of all brought together. And there's some best practice ones in there too.
Awesome. Thank you. We are a little bit over time, but thank you all for staying with us and joining us today. And thank you again to Heather for presenting. We will have our next session September 23rd from 1 to 2 p.m. And I'll send out some information about that tomorrow. We hope you will join us, and thanks for joining us today.
Thank you so much, everyone.